Hi everyone, my name is Tiffany Jones, and today, as a part of Advanced Clinical Procedures, I will be presenting my periodontal assessment project. All right, here we see our patient, Joseph Klein. Joseph is a 43-year-old male. He has Down syndrome, or also is known as trisomy 21. When it comes to age, I know we said Joseph was 43, but for a 50-year-old patient with Down syndrome, the average IQ equates to about an 8 or 9-year-old. And for a 30-year-old patient, the average IQ equates to a 5.5-year-old. So maybe if we cut that in half, add a few years, with Joseph being 43, we could maybe say he has the IQ of a 7-year-old, but that varies greatly depending on the individual. All right. Joseph is a Caucasian. He is a picky eater. Unlike most people, he likes fast food and sweets. He lives with his elderly parents, and his two older siblings do not live close by. They live in other states. He is accustomed to his routine and enjoys riding his bike, and he goes to his favorite hangouts, his favorite pizza place, and coffee shop. Alrighty, here you see Joseph has hypertension associated with cardiovascular disease. Cardiovascular disease is a very broad category that many things fall under. And patients with Down syndrome have a lot of cardiac complications throughout their lives. Joseph was born with atrioventricular septal defect. It's the most common defect seen in babies with Down syndrome. This results in a large opening in the center of the heart. Joseph had this repaired before he was 6 months of age, which is recommended, and it was corrected with surgery. Unfortunately, many years later, Joseph experienced another cardiac disorder called mitral valve prolapse. It's a residual defect associated with atrioventricular septal defect, and it's very common. And it occurs in more than half of adults with Down syndrome, even if they have had no other previous cardiac issues. So this is really important for the dental professional and any healthcare professional to be aware of. Many patients with Down syndrome, regardless of whether or not they have previous cardiac issues, should have a cardiologist screening them regularly to make sure that nothing is going on or developing. They're also at risk for developing valve dysfunctions, which could lead to cardiac heart failure. So Joseph had mitral valve prolapse, and he underwent a valve replacement, and he sees his cardiologist regularly. This is a red flag to us because with the mitral valve replacement, Joseph's cardiologist recommends a pre-med prior to treatment. Anyway, off topic. Back to the medications Joseph is prescribed for hypertension. He's prescribed two, metoprolol, and he takes the brand name Lopressor, which is recommended to be given initially at 50 milligrams, and then it's titrated until the proper dose is achieved in order to regulate the blood pressure. And Joseph takes this medication divided in two doses. So in the initial part of the day, he takes 150 milligrams, and that later on in the day, he takes an additional 150 milligrams to equal the 300 milligrams that is especially tailored to him. Special considerations when taking metoprolol are severe hypertension, and this is more so associated when you start compounding hypertensive medications on top of one another, which any cardiologist should be aware of and should be avoided. Contraindications associated with metoprolol are with NSAIDs, so he cannot take ibuprofen or Aleve. Acetaminophen should be avoided. Antidepressants should be avoided, and heartburn medications. Oral effects of medications, these are only due to the metoprolol. See, there's sore throat, sores and ulcers in his mouth, bleeding gums, xerostomia, and dysphagia, which is altered taste. Hydrochlorothiazide is also used. It's a diuretic, and Joseph takes 25 milligram tablet a day. He can also not have NSAIDs with hydrochlorothiazide. He should not drink alcohol as it can worsen the side effects and it can lead to impaired kidney function. Contraindications associated with hydrochlorothiazide are a hypersensitivity to sulfonamide drugs, diabetes, kidney and liver disease, glaucoma, and asthma. Some oral effects of his medications with hydrochlorothiazide are blue lips, bleeding gums, xerostomia, fruity breath, petechiae, swollen tongue, white lesions, a sore throat, and tenderness in his salivary glands. Here you see some overlap with sore throat and sores in his mouth, bleeding gums, and xerostomia. So those are definitely ones you want to be keyed into to watch out for. However, I don't have any medications associated with Down syndrome because they do not medicate patients with Down syndrome for Down syndrome. It's not a treatable disease as it is a genetic condition. So I'd just like to talk about maybe some things that you could see that are commonly associated with patients with Down syndrome, conditions in their mouths that you'd want to be aware of. Well, traditionally, patients with Down syndrome have premature eruption of their permanent teeth. Many teeth may be missing. They may not receive a permanent dentition. Their roots of their teeth could be shortened and they could be conical. The delayed eruption of permanent teeth is associated with a smaller maxilla and a prognathic mandible, which a prognathic mandible can cause a prognathic relationship between the maxilla and the mandible. This can contribute to Joseph being a mouth breather, and due to the fact that patients with Down syndrome also have airway problems, this could also contribute to Joseph being a mouth breather. Patients with Down syndrome have a high vaulted palate. This does not give their tongue a lot of room in their mouth, which may also be a reason why they have an open bite. Patients with Down syndrome have a very high risk of developing periodontal disease. They're not as common as normal patients as far as caries development. It almost seems like they have something that prevents them from developing caries at a normal rate. However, with patients with Down syndrome liking a cariogenic diet and perhaps taking medications that cause xerostomia, Joseph is at a normal increased risk for developing caries. Also, patients with Down syndrome develop cracks and fissures in their tongue, which trap bacteria and can cause halitosis. All right. Moving on to the periodontal assessment, Joseph has ADA case type 4, generalized severe periodontitis. This is evident. Joseph has greater than 5 millimeter clinical attachment loss, generalized throughout his dentition, and his pocket depth generalized 6 millimeters and above. He's got a lot of recession throughout his dentition, and as you already see, he's already missing a lot of teeth, either from his severity of periodontitis or in the anterior regions. He could have been prone to a fall, which could have contributed to a loss of teeth. You also see he's got 2 teeth that are mobile, class 2 and class 3 mobility. He has a high percentage and probability of losing those teeth, and he's got furcation involvement on the mandible in teeth number 19 and 30. This is a class 2 furcation seen. He also has generalized bleeding. He came into the practice with necrotized ulcerative periodontitis, and his tissue is very sensitive and inflamed. And you definitely see that it's indicative in how much bleeding he has. His AAP, periodontal classification, which we were able to make with the help of his health history, we have determined Joseph to have non-plaque induced gingivitis caused by his genetic condition, Down syndrome. He has generalized chronic periodontitis that is case type. It's very severe with more than 5 millimeters of clinical attachment loss. He also has a genetic disorder. He has Down syndrome, and Down syndrome and periodontitis go hand in hand. He also presented with necrotized ulcerative periodontitis, and due to his genetic deformities, he has short roots, so we can see on his radiographs, and he could have occlusal trauma due to malocclusion of his teeth. His ADA periodontal case type, he's class 4 severe periodontitis with more than 30%. It's generalized. His probing depths are 6 millimeters and above. He's got generalized bleeding, and he also has recession. He has furcation class 2 and 3 on tooth number 19 and tooth number 30, and mobility 2 and 3 is seen on tooth number 5 and tooth number 13. On his radiographs, you see alveolar bone loss, 5 millimeters and above. You see horizontal and vertical bone loss, 5 millimeters of clinical attachment loss. You see furcations visible on the radiographs, and he has a crown to root ratio of 2 to 1, and you can see more than 30% radiographic bone loss throughout his dentition. His gingival description, he presents with gingival color generalized moderate dark pink to red. It involves the free, attached, and papillary gingiva. The contour presents as generalized, severe, rolled and rounded margins with clefting and recession into the attached gingiva, and generalized bulbous and punched out papilla. The consistency presents as generalized severe, soft, spongy gingiva that involves both the free and attached gingiva. Surface texture presents as generalized moderate, shiny gingiva with fibrotic tissue and a loss of stippling. Here are the assessment statements, all laid out in a nice convenient table. Here you can also see his radiograph and one picture of his mouth. Here is his radiographic image. Here you see I chose a pano. Patients with Down syndrome might be a little bit better able to handle one x-ray, and this one lets us get a full picture of all of his teeth and his bone loss. Here you can see vertical bone loss, a possible class 2 mobility, and possible class 3 mobility. This furcation could be a class 2 or 3. He's got horizontal bone loss, which resulted in 5 millimeters and above clinical attachment loss. You can see a clear crown to root ratio, a 2 to 1 ratio with more than 30% bone loss. Another common occurrence in patients with Down syndrome is osteoporosis of the bone, and here you can see one area where the bone might be starting to osteoporose. Here is the first gingival image. Here you see fibrotic tissue, spongy gingiva, you see some white patches, which is associated with metoprolol and hydrochlorothiazide. His gingiva presents as erythematous. He's got ulcerated margins, and also patients with Down syndrome are prone to have high frenal attachments, which could attribute to tooth loss or recession of the gingiva. The next gingival image also, it shows recessed gingiva, cratered papilla, definitely erythematous margins, white patches on the picture to the right. The margins are rounded, punched out papilla. You can see a loss of stippling and also high frenal attachment right there between 24 and 25 in the picture to the left. This image shows us kind of something different. You see that hyperplastic, that fibrotic, swollen tissue, clefting marginal gingiva, festooned margins. Gingiva looks like it's probably really soft and swollen. Ulcerated margins, loss of stippling. This image also shows a loss of stippling, punched out papilla, lots of recession. You see a lot of root on these teeth. Very shiny, free gingiva, and has that bright red color. You see bulbous papilla. The dental hygiene diagnosis, ADA case type 4, severe periodontitis, listing some of our outcomes that we expect along with our prognosis. I rated Joseph's condition as a questionable to hopeless prognosis. My rationale being inadequate attachment of many teeth, with many already extracted due to mobility and recurrent infection, and we see this currently in his examination. He also has shortened roots in the anterior due to his congenital defect, Down syndrome. Long-term goals, we'd like to eliminate the risk for caries due to xerostomia and stabilization of the bone loss, hoping to save the teeth he still has. We want to put him on a frequent recall to check on his prognosis and his progress with home care and his periodontal maintenance cleanings. In the short term, we need to remove his mobile teeth to eliminate the nidus for infection. We need to educate him on adequate home care so he can remove the biofilm daily. And we need to reverse the necrotizing ulcerative periodontitis to eliminate that and get him on track with better nutrition to keep it at bay. At home, he's going to use a home fluoride toothpaste and a night tray with fluoride in it. He can also use a night guard. Due to his occlusal relationship, undue strain can be placed on certain teeth, and a night guard can help rid any residual effects of that. And we might also want to look into sealants to prevent decay if the xerostomia cannot be remedied. Here you see some of his modifiable risk factors. We'd like him to cut down on sweets. He can sip on water throughout the day, adequate removal of biofilm, of course. So he can use supplements to help get his blood pressure under control, and he can use fluoride to keep his teeth nice and strong. Some non-modifiable risk factors Joseph has. He has congenital heart defects with a mitral valve replacement associated with Down syndrome, and he has acquired hypertension. Moving on to his treatment plan. We're treating Joseph as a current patient. So he'd come in, have a limited oral exam, problem focused due to his necrotizing ulcerative periodontitis. And he'd have a comprehensive periodontal exam to evaluate bone levels. We do a full mouth probe on that exam. We'd also like to do a preliminary debridement. And then he's also going to be in for 4 quads of scaling and root planing. We'd also like to deliver antimicrobials subgingivally to kind of help irrigate and clean out that infection he has. Of course, we're going to put a topical fluoride, and he will have a home fluoride as well. And I think for Joseph, it's very important that we do have thorough oral hygiene instructions at every appointment. And, from one appointment to the next, you can see where he is gaining more knowledge and where you might have to put a little bit more education and time into play. And of course, we'd also like to look into placing some sealants as we see necessary. Here is his treatment plan flow chart. He presents with necrotized ulcerative periodontitis, painful gingiva, heavy biofilm, and heavy calculus. So we'd start by doing a limited periodontal exam, problem focused due to the necrotized ulcerative periodontitis. After the exam, unfortunately, we'd have to stop because Joseph needs to pre-med. So he would take his pre-med, or maybe he would come in already pre-medicated because we know that he has to based on his health history. So if he has pre-medicated already, we can do his debridement. And after that, he can go home. We give him prescription Paradex to help get rid of that infection and clear him up and kind of get rid of the bleeding, keep that at bay so that on his next appointment, we can start the scaling and root planing procedure. So he'd come in on the next day, also having pre-medicated, and we would do the comprehensive periodontal exam where probing would be done. We do his SRP on the upper right. In this appointment, we can also do gingival irrigation and his first training in preventative care. On a subsequent appointment, we would come in, bring him back for another scaling and root planing on the upper left. Again, you're going to irrigate, and we also administer ClinPro 5000. The next appointment, we bring him in to SRP the lower left. We're going to irrigate again, and we'll determine his need for sealants. On his last SRP on the lower right, we're going to irrigate, and we're going to place antimicrobials, Arestin or Periochip, in the areas that we deem necessary. As far as instrument selection, we would select standard after 5 and mini 5 Gracies, both standard and rigid. And our rationale for this is that they're finishing curettes for light to moderate calculus and an extended shank for reaching into deep pockets. The scalars we would select are the Nevi 1, 3, and 4, the Barnhart curette, and the Diamondtech, just to name a few. The Diamondtech is great for scaling furcations, and we know Joseph has 2. And the rest are great for moderate supragingival calculus removal. The ultrasonic inserts we like to select are, besides the slim lines which are pictured in the graph, we'd also like to select right and left inserts, the Beavertail for heavy supragingival calculus, and the Powerline 1000 and 100 inserts. These are for heavy, tenacious supra and subgingival calculus removal. All right, there's Joseph, and we're getting ready for his home care recommendations. Alrighty, for Joseph's nutritional analysis, hypertension is high blood pressure, and it has no symptoms, but it can lead to serious health conditions or death. And due to the risk of hyperkalemia, while taking metoprolol, patients are advised to omit foods high in potassium, like bananas, potatoes, prunes, oranges, tomatoes, raisins, artichokes, and lima beans. Down syndrome, the most common genetic disorder in live births, affects every organ in the body and has negative implications for a healthy lifestyle. A balanced diet consisting of lean meats, fruits, vegetables, and whole grains will not only help patients with Down syndrome stay healthy, it will also help maintain a healthy blood pressure. So some things to add to the diet: nuts like pistachios, fresh berries, fish with omega-3s like salmon, arugula, kale is dark leafy green vegetables, oatmeal, and dark chocolates. They should omit frozen foods, frozen pizzas, pickles, powdered potatoes and rice, deli meats because of the high sodium, canned soups, and bananas. This is a tricky one, bananas. Hyperkalemia is caused by metoprolol, a beta blocker. But hydrochlorothiazide, his diuretic that he's taking, causes hypokalemia. So I feel like it's a balancing act with those 2 medications when it comes to the potassium needed in a diet. And I think careful monitoring of potassium in the patient's diet, accompanied by the advice of his dietitian and cardiologist, should determine whether or not this patient stops eating bananas or can eat bananas, whether they need to take potassium or whether they need to excrete potassium. He should avoid alcohol and coffee, fennel and aloe. These fennel and aloe affects hydrochlorothiazide, and aloe increases the risk for hypokalemia. He should also avoid apple cider vinegar, garlic, and artichokes. Some supplements he should take. Potassium, again, controversial. Do I add it to the diet or do I take it off? Magnesium is very beneficial. CoQ10 is seen as very beneficial with high blood pressure and lowering that. It's also been shown to decrease rates of Alzheimer's, which patients with Down syndrome have a high risk for getting at earlier times in their lives than the normal population. They should also include vitamin E and iron supplements. Okay, as you take a look at my grading rubric, I'm just going to talk about some things that I may have omitted when it comes to treatment of a patient with Down syndrome. You need to coordinate with the caregiver effective techniques for managing the patient behavior. A caregiver probably always accompanies a patient with Down syndrome, so they are your best resource for how to best take care of the patient. And most patients with Down syndrome are warm and friendly and well behaved, but at first they may come off as uncooperative at first or stubborn. So some things to combat that are having appointments early in the morning And try to involve everyone from the front desk staff to other people in your office to make it a friendly environment that's welcoming to the patient with Down syndrome. And since you're going to be seeing him over multiple appointments, make it consistent from appointment to appointment. All right, that's all I have for you today. I hope you enjoyed. Thank you.